A very good morning to everyone. I'm highly thankful to the NEMA Society for giving me the chance to interact with Ayurvedic practitioners, doctors and scholars over here. Uh, the last session which was done about luteal phase defect, which is a very important topic for the treatment of infertility. So once the woman is conceived, now the point is to continue the pregnancy and maintain it till 9 months and give a healthy baby to the mother. So here today I'll be discussing some of the important topic, which is implication of infertility and pregnancy outcome in the reproductive endocrinology in a Rh negative woman. Being a medico, I do understand. We need a lot of theories, we study, go through literature. But once we assess and correlate it with the case, it incorporates deep into our mind and we remember the topic better. So let's understand what is this Rh negative woman and why are we concerned about it and what are the fetal prognosis and important points in it. Let's understand this with the help of a case scenario. She is a B negative woman. Her age is 31. She is the fourth gravida prior to living one and abortion one. So that means if we see the case, she has conceived 4 times, but she's only having a one live baby with one abortion and one pregnancy is mishap. So what should be done as a healthcare profession in or after the pregnancy, because she has missed the Rh prophylaxis in her previous pregnancies and miscarriage. So what happened in the case in the term of fetal and neonatal outcome? So when we see, if we know that she is having a POH, like bad obstetric history, because she is having one fetus, but there is abortion, second, the baby died, and now she is pregnant. So what as a medical profession or as a healthcare profession we can help this woman with? So let's see what is basically Rh immunization, the prevalence of Rh negative in globally and the nationwide. What is the pathophysiology of Rh negative incompatibility? The causes, the risk factors and the potential sensitizing event. Because if we don't know the potential sensitizing event, it would be so difficult for us to treat it and to help that woman. The complications, what are the investigations, how we can diagnose Rh incompatibility, the management, treatment, guidelines and finally the conclusion. So what is this Rh isoimmunization? The Rh stands for rhesus factor, iso is similar and immunization is production of antibodies in an individual in a response from another individual of same species. That means if the antibodies in a woman is produced from the antigens of the same species, this is Rh isoimmunization. So there are the two terms, which is incompatibility and the isoimmunization. Incompatibility, suppose if the woman is Rh negative, that means her blood group is Rh factor is negative and her husband is Rh positive, and so the baby growing in her womb is Rh positive, then the mother and the fetus, they are incompatible as per the Rh factor. So this is an incompatibility. And if because of any of the need, if the mother starts producing antibodies against the Rh factor, this is Rh hypoimmunization. So before understanding what is this rhesus factor, this Rh factor is basically the genes and the alleles which are present on the RBCs. Usually the alleles are of C, D, E, small c and E, out of which DD, if it is in a homozygous condition, it will be Rh positive. Capital D if present on the surface of RBC, then the woman, the male or anyone would be Rh positive. And if it is in heterozygous, capital D and small d, it will be Rh positive. Small dd alleles will always give a Rh negative blood type. Why this is so important? Because if we see the global prevalence of Rh negative, yes, I know it depends from country to country, but The Rh negative Caucasians are maximum, like in North American and European population, it accounts for 15 to 17%. In Asian, it accounts only for 0.1 to 0.3%. It doesn't mean that if 0.1 and 0.3% is in our Asian population, but every life is important for us as a medico. So we have to know about what is this Rh incompatibility and how we can guide and improve the prognosis. This Rh incompatibility depends on the prevalence in the population. If it is untreated, then 50% of the neonates die because of the brain damage fetal anemia. Looking into the Indian scenario, if we see the various regions of the India, the Rh positive counts for 5 to 8% of the Indian population. Maximum incidence or maximum prevalence being in the northern state, which is around 7.12%, the least in the eastern, which is 2.58%. So let's understand what happens exactly in an Rh incompatibility. In Rh incompatibility, when a Rh negative woman married a Rh positive man and is having a baby which can be Rh positive, then if because of any sensitizing event, if there is a leak of Rh positive into the maternal circulation, then the immune response mounts. But as we all know, the first immune response is IgM antibodies. These IgM antibodies, we know they are bigger size, so they will not cross the placenta. But, so most of the time, the first pregnancy is least to be affected or it is not affected. But when again she becomes pregnant second time, then what happens? There will be an immense response because already the woman is sensitized. Again, if there is a leak because of Rh positive coming into the Rh negative, then the response will be high and the production of antibodies will be IgG type. And IgG will cross the placenta and will damage the fetus. So if we see, the most of the time, it is the subsequent pregnancies or the second pregnancies which are affected with the help of Rh incompatibility. So the second pregnancy, what happens? This IgG antibody, when it crosses the placenta, enter the fetal circulation, it will start destroying the fetal RBCs. इसका मतलब खून, बच्चे का खून पानी बनना शुरू हो जाता है. In short, this is how you can remember. Okay? So this will lead to hemolytic anemia, the damage. The jaundice can be from mild to severe variety depending on how much is the sensitization. Now, if you know what is the pathophysiology, we should know what are the culprit or the causes and the risk factors. So, the exposure, one is the exposure to the Rh positive factor in the woman and non-fetal exposure of Rh positive. This can be either abnormal blood transfusion, so you have to be very careful while transfusing the blood. Rh negative women should not be given Rh positive blood anytime. Bone marrow transplantation, the blood cross matching or the blood group type is very important, and needle stick injuries. Exposure to the fetal Rh factors, these are deliveries, fetal abortion, trauma, the external cephalic version, invasive procedures like CVS, chorionic villus biopsy, amniocentesis, ectopic pregnancies, molar pregnancies, antepartum hemorrhages like placenta previa, abruption, and the rupture. And if I categorize the pregnancy, first is the first trimester, it is less than 12 weeks, and the second, the later pregnancy, the second and third, more than 12 weeks. In the first trimester, the main potential sensitizing events are the abortions, right? Bleeding, subchorionic hemorrhages, internal hemorrhages, vesicular hole, ectopic, surgical termination of pregnancies, the back. If it is more than, there is some error like mistake. If it is more than 12, amniocentesis, abruptio placenta, blood trauma, intrauterine fetal death, external cephalic version, which is usually done for the breech, and the placenta previa with the bleeding. These are the potential sensitizing event which occurs in the later hour. So what do we understand by the fetal-maternal hemorrhages? Fetal-maternal hemorrhages is basically the mixing of the fetal blood into the maternal circulation. Usually, This is very rare. Only 1 ml of mixing occurs in 96% of the population. That's why we are very sick. But sometimes there can be abnormal fetal-maternal hemorrhages, and the entity one is the silent fetal-maternal hemorrhage. This is silent fetal-maternal hemorrhage. This is very critical because here the mother will have no symptoms and it will lead to the death of the fetus because of severe neonatal anemia. If you see the trimester wise, what are the chances of fetal-maternal hemorrhages? Then in the third trimester it is around 29% and in delivery it is 76%. So most of the time the third trimester and the delivery, these are the crucial time for the mixing and the production of antibodies. If we see the quantum of the leak, then the quantum of the leak, if it is more than 5 ml of blood from the fetus going into the maternal circulation, then 65% chance are for the sensitization. So in short, how to remember? More the leak, more the chances of sensitization, the more adverse fetal outcome. So what does this complication or what does this lead to the baby? So in the antenatal period, this leads to erythroblastosis fetalis, fetal anemia, hydrops, kernicterus and hyperbilirubinemia and jaundice. In the perinatal, it will lead to erythroblastosis neonatal, hydrops and neonatal hyperbilirubinemia and jaundice. So what happens in this? When the fetal blood starts, the RBCs of the fetal blood start destroying, then yes, if RBCs are destroyed, hemoglobin will fall, then fetus will have anemia. If once the anemia is there, then there will be a raise of bilirubin level in the body and this will lead to the kernicterus. So how we quantify how much anemia or what is the severity? So this can be done with the help of hemoglobin deviation from mean gestational age, hematocrit if less than 30, hemoglobin value expressed as MOM. This MOM is median deviation from the mean. If it is more than 70 gram per deciliter, hemoglobin deviation, and if hematocrit is less than 30%, then this means that the baby is severely affected. So what are the signs? How this will present? This will present as polyhydramnios, enlarged fetal heart on ultrasound, ascites and pericardial effusion, reduced fetal movements, hyperdynamic fetal circulation, and abnormal CTG and reduced variability. The hydrops is basically the swelling of the fetus. It feels like the water has been accumulated in almost all the compartments. This is because of immunological response. That's the reason it is called as immune hydrops. There are few infections in which this hydrops picture takes place. So that is categorized into non-immune. But here, what happens? All those blood-producing organs like liver, spleen, everything. Because RBCs are destroyed, so these organs are stimulated to produce more RBCs. So they start enlarging and the fluids start accumulating. So the large amniotic fluid, the symptoms during the pregnancy is thickened placenta. The ultrasound shows enlarged liver, spleen, heart, and the fluid build-up in the fluid. So if on an antenatal ultrasound, if you see placentomegaly, first rule out infection. If you see placentomegaly with enlarged liver and spleen, think about the fetal anemia or maybe the anemia is setting in. Third, if you see the fluid into the abdominal cavity, this is going to be the first sign on the ultrasound. Again, if the RBCs start destroying, there will be hyperbilirubinemia and jaundice. 60% of the term newborn have jaundice in the first week of life. So this is normal. But if the jaundice is more, then it got a poor prognosis. The fluid discoloration of eyes, skin, and if this bilirubin start accumulating in the brain, it gives to the kernicterus. So what are the clinical manifestations? Usually, the baby presents like lethargic, hypotonia, irritability, poor feeding, a high-pitched cry, MSS. Early signs are noted after the 4 weeks. The later signs are bulging fontanel, of histotonus, like of histotonus condition, pulmonary hemorrhages, fever, hypertonicity, and paralysis. maternal or the father or the husband blood group should be asked for. If the father or the husband is positive, then you should go for an antibody titer at 26 and 28 weeks. If the antibody titer start rising, then you should suspect that there could be some sort of disturbance. There are two important tests we always read about: direct home test and indirect home test. It is very confusing when I was doing my MBBS and PG. I always have to mug it up. Direct कब कराएंगे, indirect कब कराएंगे. So in short, direct means already sensitized. So if direct home test will be done from fetal blood, so that means direct home test is offered after the delivery. Because if the fetus is affected or the antibodies from the mother has been passed into the fetus, we'll ask for a direct home test. Indirect home test is basically done as a screening test for sensitization in this condition. So in antenatal period, we'll ask for an indirect home test. If indirect home test is positive, that means sensitization हो चुका है. इन पेशेंट्स का ध्यान रखना है, इन पेशेंट्स का टाइटर्स करवाना है, इन पेशेंट्स को एंटी-डी एज अ प्रोफिलैक्सिस नहीं देना, because already they are sensitized. So indirect home test, if it is negative, then yes, it comes. Then there is the role of anti-D, the prevention and everything. The two other tests to know how much is the leak. These are the two important tests. One is the Gaussian test, in which if there are fetal RBCs in the maternal circulation, then treating this with the enzyme-treated indicator, there will be aggregation, with the growth formation. So this points that yes, there is a fetal-maternal hemorrhage. We can quantify this with the help of Clear-Belkis test, because anti-D giving as a prophylaxis depends on how much amount of fetal-maternal hemorrhages has occurred. So once the blood serum is fixed on the ethanol slide, it is treated with lactate phosphate buffer and H&E staining was done. H&E staining means the characteristic of fetal blood are the RBCs, they don't rupture. The fetal RBCs are not that fragile as adult. So once we treat with the citrate buffer and ethanol, the adult RBCs they blast goes like a million, and the fetal cells will remain big. So number of fetal cells by number of adult cells will give us and quantify how much is the leak and how much dose of anti-D we have to give. This is one of the most important tests to know the degree of fetal anemia. This is middle cerebral artery Doppler. If there is a fetal anemia, then the oxygen carrying capacity of the blood has reduced. This will lead to rise in peak systolic velocity, and if rise is more than 1.5 mmol, then you suspect the fetal anemia. This is the early and the serial Doppler assessment is important. What are the other signs if we see on the ultrasound? These are subcutaneous edema, ascites, pleural effusion, pericardial effusion, which can be consistent with the severe fetal anemia. The other non-reliable signs are the placental thickness, the umbilical vein artery diameter, the hepatic and the splenic size increases, and the polyhydramnios. This is one of the important first signs of impending hydrops. This is the visualization of the fetal bowels from the small amount of intra-abdominal fluid. So intra-abdominal fluid are the first thing to develop, and on ultrasound we can see these bowels. So how do we manage? We manage the pregnancy. It is categorized into two, whether it is unsensitized pregnancy or a sensitized pregnancy. If there is no mixing, that means unsensitized pregnancy, suppose at 28 and 32 weeks, if you have not found it, the indirect mood test is negative. It is unsensitized pregnancy. There comes the rule of anti-D. The overall, the Rh negative mother to Rh fetus, the overall risk of sensitization is 16%. If we give a antenatal anti-D, then this sensitization reduced from 16% to 1%. And further to 0.1. If you give anti-D in the postpartum period from 16 to 1%, the chances of sensitization decrease. If you give it in an antenatal period also at around 28 to 32 weeks, it reduces from 1% to 0.1%. So there is a big role of prophylactic or preventive anti-D in the antenatal period. So what does this anti-D do? This anti-D, when enters the maternal circulation, it starts destroying the fetal Rh positive cells in the maternal circulation. So for all the Rh negative women, the most important is the careful history. Ask for the losses, the abortion, any history of ectopic pregnancies, the neonatal jaundice, or any baby who suffered from severe jaundice, death, history of blood transfusion, and whether she received anti-D in her previous pregnancies or not. Second important point is check for the husband blood group and Rh factor. Now the preventive role for prophylactic anti-D should be given at 28 to 30 weeks and following an episode of antenatal hemorrhage, spontaneous, and check for the sensitizing event. And the postnatal anti-D should be given as early as possible, but it can be given up till 72 hours. Then it can have a maximum efficacy. The Rh negative mother with the Rh positive, this is the repetition. Basically, the more we repeat, it just gets incorporated and consolidated into the memory. So, it's just giving anti-D prophylaxis within 72 hours. Few studies have stated that, suppose we don't know about the blood group of the mother, it is delivered into some benefit. Few studies say that even some benefit can be given if anti-D is given as late as 28 weeks. That doesn't mean कि अरे हमने पढ़ा है 28 days तक हम एंटी-डी दे सकते हैं तो 28 days तक वेट करना है. No. The first important thing is give it as early as possible. Like the baby delivered, the blood group should be sent immediately within half an hour. The report comes and give anti-D. The earlier you give, better the benefit. But suppose if woman delivered at home, she came to you late. This can happen in the rural places. Then maximum you can give within 28 days also, but the dictum, the rule is give it as early as possible. So what are the precautions you have to take during the delivery of an Rh negative woman? No methogen should be given after the delivery. Methogen, as you all know, it's a uterotonic. It is a very potential drug to treat postpartum hemorrhages. But the contraction with the methogen is very strong, so that increases the chances of fetal-maternal hemorrhage. So methogen should not be given. No manual removal of the placenta. ऐसा नहीं है, मतलब no manual मतलब purposefully नहीं निकालो manually. Let wait for the oxytocin to act on so that the placenta separation happens automatically or with the help of drug. If sometimes we are in very hurry, like female obstetrician, I have seen people like before separation of the placenta, they just enter into the uterine cavity and start scratching the placenta. It should not be done because this will lead to potential sensitizing behavior. The cord blood sample collects for hemoglobin. Now the direct mood test. This is what I said. Direct in the baby, indirect in the mother. And anti-D 300 microgram within 72 hours of the delivery for the new. So what are the potential events which we should know कि इसमें 300 microgram of anti-D will not work? We should think. So this is a intrauterine fetal demise, manual removal of placenta, abruption and the bleeding placenta. In this whole condition, you have to go for a pure pancreas test to quantify how much maternal leak is there and then give dose of anti-D accordingly. This is something which almost every one of you know. I don't read it. This is a pediatrician who do it. If the fetus develops jaundice, tourniquet, then yes, chemotherapy needs to be given. It can be intensive or a the case again, she is a B negative woman with a normal delivery of the girl in 2013. She had a miscarriage in 2019 and DNC done. But no NTD was given to this woman. Again, she became pregnant in 2020. She delivered a normal baby. She had a neonatal death because of hemolytic disease of pneumonia. Again, in 2021, when she came, then there will be intensive monitoring and the baby will be fed only after transfusion. So this is all related to the sensitization of the mother with the Rh positive fetus because the prophylactic NTD was not given. If you want to help the women of such case scenario, it is always better. First important thing is give NTD as early as possible in the first trimester, in the case of the first abortion, any sort of first delivery, because first is the most important time where you can save the woman for later on the subsequent pregnancies complications. In this case, when she is pregnant now, the dexamethasone should be given for the lung maturity. If the fetal, MCVA Doppler shows high 1.5 mmol, then the blood transfusion is advised. So the most important take home message is give NTD at the hospital, and the quality of life would not be compromised in the following if universal antenatal blood group type and ICT is done for the Rh negative woman. Ensure NTD after antenatal and postnatal delivery, miscarriages and invasive procedures, and importance of keeping a medical record. These are all the protocols, these are all the guidelines which we follow in our practices. These are ACOG, RCOG, FOXY. FOXY is our Indian guideline which all say that NTD should be given. The 5 pointers for the right to management are: when woman comes to you, blood group should be done. If her blood group is negative, blood group should be done. ICT should be done. And if it is negative, give NTD and save her from sensitizing events. Thank you so much.